Hello, and welcome back to the Therapeutics Chronicles. I'm your host, Momin Wali, and today we are diving into one of the most talked about medications in metabolic health, semaglutide. Whether you are in internal medicine, endocrinology, or primary care practice, this is a drug that has likely made its way into your practice. Semaglutide has taken the medical world by storm, not just for its role in diabetes, but also for its impact on weight management. But with great popularity comes great misconceptions, common prescribing mistakes, and real-world challenges that can affect patient outcomes. Today we will cover its mechanism, dosing, adverse effects, clinical pearls, and even some real-world case scenarios to sharpen your therapeutic decision making. Before we get started, do not forget to join our growing community of healthcare professionals in our WhatsApp and Telegram groups. Whether you are tuning in for the podcast or preparing for pharmacy board exams, these groups are where clinical discussions happen in real time. The links are in the description, and I would love to see you there. If you would like to connect with me professionally, feel free to reach out on LinkedIn. Let's keep the conversation going. Semaglutide belongs to the class of GLP-1 receptor agonists, a group of drugs that have revolutionized diabetes management. GLP-1, or glucagon-like peptide 1, is an incretin hormone that plays a crucial role in glucose homeostasis. When we eat, GLP-1 is released from the intestines, stimulating insulin secretion, suppressing glucagon release, and delaying gastric emptying. The result is improved blood sugar control with a lower risk of hypoglycemia compared to insulin or sulfonylureas. But that's not all. GLP-1 receptor agonists also reduce appetite by acting on the brain's satiety centers, making them powerful tools for weight loss. This is a key reason why semaglutide is not just a diabetes medication. It has gained FDA approval for chronic weight management in non-diabetic patients as well. Semaglutide is approved for type 2 diabetes under the brand names Ozempic, the injectable form, and Rybelsus, the oral formulation, and for weight management under the name Wegovy. It is also used off-label in metabolic dysfunction-associated steatohepatitis, formerly known as NASH, given its effects on reducing liver fat. The injectable formulation follows a gradual titration schedule to minimize gastrointestinal side effects. For diabetes, Ozempic is started at 0.25 mg once weekly for 4 weeks, before increasing to 0.5 mg once weekly, with further increases to 1 mg or 2 mg weekly if needed for glycemic control. For weight loss, Wegovy follows a similar pattern, starting at 0.25 mg weekly and increasing every 4 weeks to a target dose of 2.4 mg weekly. The slow titration is essential to reduce nausea, which is one of the most common side effects. Oral semaglutide, Rybelsus, starts at 3 mg once daily for a month before increasing to 7 mg daily, with a maximum dose of 14 mg. Unlike the injectable version, Rybelsus requires careful administration. Patients must take it on an empty stomach with a sip of water and wait at least 30 minutes before eating or drinking anything else to maximize absorption. The most common adverse effects are gastrointestinal, including nausea, vomiting, diarrhea, and constipation. These are dose-dependent and tend to improve over time. Gastroparesis is a concern because semaglutide slows gastric emptying, which can worsen symptoms in patients with pre-existing delayed gastric motility. Pancreatitis is rare, but a serious adverse effect, so any patient experiencing severe persistent abdominal pain should be evaluated. There is also a theoretical risk of medullary thyroid carcinoma, which is why semaglutide is contraindicated in patients with a personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome type 2. Hypoglycemia is uncommon when semaglutide is used alone, but the risk increases when combined with insulin or sulfonylureas, so dose adjustments may be necessary. Delayed gastric emptying can affect the absorption of other medications. Patients on levothyroxine, warfarin, or oral contraceptives should be monitored for changes in drug levels or efficacy. Combination therapy with SGLT2 inhibitors enhances weight loss and cardiovascular protection, making this a valuable approach in high-risk diabetes patients. Let's go through some real-world case scenarios. A 52-year-old patient with type 2 diabetes starts semaglutide 0.25 mg weekly and returns after 2 weeks complaining of nausea and occasional vomiting. This is expected and often transient. The best approach is reassurance, encouraging smaller, more frequent meals, and avoiding high-fat foods. If symptoms persist, delaying the dose increase may help improve tolerability. A 38-year-old woman is on Wegovy 2.4 mg weekly for weight loss. She has lost 15% of her body weight in 6 months, but now reports early satiety, bloating, and occasional vomiting. These symptoms suggest gastroparesis-like effects, which can occur at higher doses. Reducing the dose or considering a drug holiday may be necessary. A 45-year-old woman with hypothyroidism is on levothyroxine 100 microgram daily and starts Rybelsus. Her TSH rises after a few months. Semaglutide's effect on gastric emptying likely delayed levothyroxine absorption. The best strategy here is to space out levothyroxine and semaglutide by several hours and reassess thyroid function. Before we wrap up, let's talk about what patients should know before starting semaglutide. Patients should be informed that nausea is common, especially during the first few weeks, but it typically improves over time. Eating smaller meals and avoiding high-fat, greasy foods can help reduce gastrointestinal symptoms. If taking the oral form, they must take it first thing in the morning on an empty stomach with a small amount of water, waiting at least 30 minutes before consuming food, drinks, or other medications. They should be aware that weight loss may occur gradually, and this is normal, but they should report symptoms of severe dehydration, persistent vomiting, or difficulty eating. It is important to discuss potential serious side effects, including signs of pancreatitis like severe stomach pain that radiates to the back, and the rare but serious risk of thyroid tumors, which is why they should inform their healthcare provider of any family history of thyroid cancer. If they are using insulin or sulfonylureas along with semaglutide, they should be cautious of hypoglycemia symptoms such as dizziness, sweating, and shaking. Lastly, they should not stop the medication abruptly without discussing it with their provider, and they should schedule follow-ups to assess response and adjust doses as needed. Alright, let's finish strong with some rapid-fire Q&A. How should oral semaglutide be taken? On an empty stomach with a sip of water 30 minutes before food. What is the biggest contraindication for semaglutide? A history of medullary thyroid carcinoma or MEN2. What is the most common side effect? Nausea. Can semaglutide cause hypoglycemia? Not by itself, but it can when used with insulin or sulfonylureas. That's a wrap for today's episode. If you found this discussion valuable, be sure to subscribe and share this episode with your colleagues so we can continue to spread knowledge and improve patient care. Have a question about today's topic? Want to discuss a clinical case or share your experience using semaglutide? Join our WhatsApp and Telegram communities. The links are in the description. Do not miss out. If you would like to connect professionally, reach out to me on LinkedIn. I'm always happy to continue the discussion beyond the podcast and exchange insights with fellow healthcare professionals. And as always, stay curious, keep learning, and most importantly, catch mistakes before they catch you. Until next time, this is Momin Wali signing off. Take care.